Hey, well, kia ora everyone, and welcome to this FONS webinar to be given by three colleagues from across in Australia. So we're really delighted to have Maura, Sally and Justin with us today. As I mentioned before, Patrick, our tech expert, is not here, so Maura has entrusted me with to manipulate the slides. So that'll be an interesting experience both for me. But before we start, I'll ask David to do a karakia, and he'll give one at the conclusion as well. And there'll be an opportunity, of course, for questions at the end. So, David.
Thanks, Barry. E noi tātou. Whakatakata hau ki te uru, whakatakata hau ki te tonga, ki a mākina kina ki uta, ki a mātaratara ki tai, e hi ake ane te atakura, he tio, he hoka, he hauhu, tihei Māori.
Great, and thanks very much, David. So it's my pleasure to introduce our three colleagues from AIHW in Canberra, Australia. Maura Hewitt is the head of the Screening Analysis and Monitoring Unit. Justin is the head of Cancer Data and Monitoring Unit, and Sally is the head of the Cancer and Screening Linkage and Data Development Unit. So they'll be presenting a joint presentation this afternoon. So Maura, and I'll get your slides.
Thank you.
Can you see that?
Yes, I can. Thank you very much.
Okay.
Happy for you to go to the next one immediately, if you like. Thank you. Just to say that we're talking about the cancer and screening data ecosystem in Australia and focusing on the role of the Australian Institute of Health and Welfare in that cancer and data ecosystem. So before I begin, I would just like to acknowledge the Ngunnawal people, who are the traditional custodians of the land on which we're presenting to you from today, and pay my respects to the elders of the Ngunnawal Nation, both past and present, and I extend this to all Aboriginal and Torres Strait Islander peoples present at the meeting today. Thank you. So just a little bit of background about the Australian Institute of Health and Welfare, the AIHW, just to set the context for which we work. The AIHW is an independent statutory authority of government and was established in 1989 under the Australian Institute of Health and Welfare Act, which 1987. Just to talk a bit about, sorry, the next slide, Barry, thanks. So just to talk a bit about what the role of the AIHW is and what our vision and goals are. So we have a key role in developing and maintaining and promoting statistical information standards for the health, community services and housing assistance sectors, collecting and managing data on health and welfare issues, including from state and territory and federal government agencies, analysing and releasing a range of health and welfare products, data and reports to key policy areas to support better policy and service delivery decisions, enhancing data resources with the addition of new health and welfare data assets to our holdings and to fill gaps in the health and welfare sectors, and modernising the presentation and availability of national health and welfare products to meet the needs of a diverse audience that we have, including state and territory, federal government agencies, universities, research centres and non-government organisations. So the organisation's vision at the moment is stronger evidence, better decisions, improved health and welfare. And move to the next slide, please. Our strategic goals for the 22 to 26 to support that vision are that AIHW is a trusted leader in health and welfare data and analysis, that we're innovative producers of data sets and analysis, we're a strong strategic partner, and we're recognised for our organisational excellence. So Great. If we could move to the next one again. Thanks, Barry. I just wanted to point out, because this is fundamental to the work that we do in the cancer and screening data ecosystem, about the Australian data integration infrastructure. The Australian Bureau of Statistics and the Australian Institute of Health and Welfare have jointly developed the Australian National Data Integration Infrastructure, and it's the underlying infrastructure for the National Disability Data Asset, and it also enables data governance and streamlined data sharing arrangements. And the AIHW is one of 2 approved national data integration authorities, which means we're able to link Commonwealth data. We've got all the processes and governance processes, ethics approval processes, and technical expertise to link Commonwealth data with other data sets. And under that, we have developed a national health data hub to support data integration. And that's an ongoing piece of developmental work. It's quite big. And it's a major national data linkage system for health and welfare research and analysis projects. And it comprises de-identified and enduring health and welfare data sets from state and territory, Commonwealth, and from non-government sources. And that's pivotal to the work that we're doing to improve data access across the cancer and screening data continuum. And so we'll talk a bit more about that in some of our slides. I think Sally's going to be focusing on that particular piece of work. Great, thank you. If you can move to the next slide, please. I'm just going to talk a little bit about the cancer and screening data ecosystem in Australia, and it's underpinned by strategic partnerships between government agencies, cancer organisations, and the Australian Cancer Plan and the National Cancer Data Framework. Yes. Sorry, is someone?
No.
I sorry, just heard someone talking. I didn't know if someone had a question or.
Oh. Couldn't see that.
No, okay, that's fine. The Australian Cancer Plan emphasises that optimal cancer care and high-performing system rely on access, use of, and sharing of reliable and comprehensive health and cancer data across all care settings. And while Australia's got a rich and diverse range of cancer data collections, their effective use is hindered by fragmentation, complex governance arrangements, and variations in data collection. And the emphasis on the sector working together to improve the availability and better measure how well the Australian healthcare system is performing. And so up on this screen, there's just the logos for some of the key partners that are involved. We also have state and territory governments involved, and state and territory cancer registries as well. So it's even more complex than what it seems on this slide. Okay, let's move to the next slide. This is just a key figure from the National Cancer Data Framework, and just pointing out the guiding principles and enablers of the data framework and the 3 strategic objectives to achieve its overarching vision. And it's the framework is setting the strategic direction for collection, management, use, and ongoing development of comprehensive and consistent health and cancer data. It aligns closely with several key initiatives and priorities in Australia's cancer control and data landscape, and supports the strategic objectives of the Australian Cancer Plan. And it also builds on broader government digital health agenda, including aspirations for seamless data across patient care and secondary research, as outlined in the Digital Health Blueprint and the National Digital Health Strategy. And the framework's development has been informed by extensive sector consultation, reflecting broad national agreement on the current state of cancer data in Australia and priorities for action. And it incorporates the concepts of Indigenous data sovereignty principles to ensure that the unique health of First Nations peoples are met. Next slide, please, Barry. Thanks. So this brings us to AIHW's role. And from that background, you can see that we're a pivotal player and a key partner in the cancer and screening data ecosystem in Australia, but it's not something that we can do on our own. So we collaborate with government agencies, cancer organisations, state and territory registries to report on national cancer and screening statistics and to facilitate research into cancer outcomes to assist policymakers, consumers and service delivery planners and managers. So you can see from the background of our own organisation strategic goals and the cancer plan and the national cancer data framework and the ecosystem, how they align quite well. And they form the basis of the focus of our current work, which is looking at data improvement and data development for national cancer stage data, improving timeliness of data, developing and building on the linkage infrastructure that we already have at the AIHW to improve the cancer and screening data ecosystem, and supporting the development of new cancer screening programs, including contributing to indicator development and specification development and development of the quality framework, etc. Okay. And just to say, at the Institute here, we have the 3 cancer screening teams that, as you described, Barry, at the beginning of the presentation. And Amy Young is the head of the population health group within which the 3 cancer and screening teams fit. And we work closely together to ensure that we can improve data and reporting across the cancer continuum. And we have developed over the years from one unit which combined cancer data and monitoring and the screening units. And they split out around, I think, 2018 as the work developed and grew. And then more recently, 2 years ago, Sally's unit was also brought on board to work to deal with the development of the indicators and reporting for the lung cancer screening program, and also the data development infrastructure. Plus there's some more work which she'll be talking about that's come on since that time as well. So that's the introduction and overview. I don't know if you want to do questions at this point or whether you would just like me to continue and reserve questions for the end.
If there is any question, anybody got any questions? I'll stop sharing the screen and set up the next one.
Sure.
So,
yeah.
Has anyone got any questions? David and I will attempt, or you can raise your hand, or alternatively put them in the chat and we can ask and look at those later and send them off to our own colleagues. Yeah. Okay.
I expect we'll have time at the end.
Yes. Okay, I'll load up the next one then.
Okay.
See that? There you go.
Yes, thank you. What I'm going to talk about now, while we do work closely together as units and we have some cross-unit projects, I'm going to focus on the key work of my unit, the screening analysis and monitoring unit. And then Justin will focus on the work of his unit, and then Sally will talk about some of the new developments in the data development unit, which is primarily being led by her unit. Right, so the Screening Analysis and Monitoring Unit undertakes a range of analytical data development and reporting work, including data linkage work to address data gaps. And we work closely with stakeholders to identify analysis needs, data gaps and options for data development and improvement. Our key responsibilities are monitoring and reporting on performance, quality and safety and operational aspects of cancer screening programs. My unit focuses on the breast screen, the National Bowel Cancer Screening Program and the National Cervical Screening Program. The National Lung Cancer Screening Program is underway and under development. It has been developed, but it's still in that development phase of collecting the first tranche of data and being able to report on that. And so that currently sits in Sally's unit. We also report on cancer outcomes and screening behaviour using linked data and work to improve cancer screening data and undertake analysis and supply of cancer screening data for researchers. So I'll go to the next slide. Thanks, Barry. Sorry, priorities. So our priorities over the current period and the next year or two are improving data and reporting across the cancer continuum. So that's around screening, assessment, diagnosis and treatment and outcomes. And those, the screening assessment, recruitment, screening, assessment, diagnosis and outcomes form part of the population-based screening framework around which the indicators for our reporting programs are developed. And I'll talk a little bit more about that later on. Provision of timely participation and activity data is to support policy and program operations. And that's particularly important for our funders, which are the Department of Health, Disability and Ageing. Developing a suite of reporting and data products that meets the needs of funders and stakeholders. So up until fairly recently, we mainly had PDF reports that were publicly available and supported by data tables, etc. And while they were presented online, they were in an easily accessible format. And that was partly historical because that's what our funders initially wanted. But as technology's developed and the world's moved forward, there's a lot more quicker and easier ways to present data, and including dashboards, web visualizations. And so we jointly did a review with, Health commissioned a review of the, not so much our work program, but of the needs for screening data. And out of that review came some recommendations around moving to a more flexible format for reporting. So the focus of our work over the last 18 months, 2 years, and for the next 2 years has been to continue to develop and enhance existing data and reporting processes, and to look at the format and frequency with which we report. Another focus of our work is improving data and reporting for priority populations, and specifically cold and First Nations populations. Plus, we also provide data to support Australia's work on the elimination of cervical cancer as well, which is a part of a national, global strategy as well. Okay. Might move to the next slide, please. This is just a brief summary of our business as usual work. We provide annual monitoring reports for Breast Screen Australia, the National Bowel Cancer Screening Program, and the National Cervical Screening Program. Biannual operational reports for the Bowel Cancer Screening Program are provided. They're not published, they're just provided to Health to facilitate their service delivery and program delivery work. We also provide a monthly statistical process control report for the bowel program, and that's really just to make sure that there's nothing wrong with the kits that we have, and to look at whether they're in bounds or out of bounds, and to flag any issues that might need further review. Again, that's an internal thing that's just provided to Health to support management of that process and the kits. Provision of data to support the National Cancer Screening Program safety monitoring and also the National Strategy for Elimination of Cervical Cancer. We maintain data dictionaries for Breast Screen Australia and the National Cervical Screening Program, and those are online, and they're highly valued by our program managers and service delivery people and data managers for the program at state and territory level. And we don't have a separate data dictionary for the bowel cancer program, but all the specifications are available in our Meteor program. I'm not sure if you've heard of Meteor, but it's a collection of metadata that we have for most of our collections. For historical reasons, the data dictionaries for cervical and breast screen don't sit in Meteor at the moment. They sit in separate things, but they are available on our website. They also contain, for the breast screen in particular, they contain a lot more data than we actually hold in the national collection, all the specifications for more data than we hold in the national collection. This breast screen, the National Cervical Screening Program, the National Bowel Cancer Screening Program, the data is held in the National Cancer Screening Register, which is managed by Telstra Health on behalf of Health, and our Department of Health, Disability and Aging are the data custodians for the whole of the NCSR data. The lung data is also in the NCSR, but the breast screen data is separate. It's a state and territory managed collection. And so we work closely with our state and territory counterparts to get that data, part of the federated system. Happy to take questions on that aspect a bit later. We also do a quarterly collection and validation of accreditation data for the breast screen program as well, which involves preparation and provision of data to support accreditation decisions by the Breast Screen National Quality Management Committee, which does that. And there's a list of national accreditation standards, and there's measures to support those standards. They're included in our breast screen data dictionary as well. And we also maintain and support the data providers with the process of collecting and providing that data, and by providing and developing a number of tools to assist that. And then we do a range of ad hoc data requests for researchers, so providing the screening data for linkage projects to our integrating data authority, and also we supply directly to supervisors working with our Department of Health, Disability and Aging on non-linkage data requests. So they're approved by both the department and us, but we do like a 5 safes assessment and a feasibility assessment, and then do all the extraction work and provide that data once it's approved. We have a range of other projects. Some are ongoing and been ongoing for a while, and there's a few linkage projects, but I'll talk about them separately later, because that flows on from some other work that I'm going to talk about first. Some specific projects at the moment to look at enhancing the national collection for Breast Screen Australia. As I mentioned before, breast screens managed by the state and territory their departments, and there's a limited amount of data that we have from them in unit record form, and some also in aggregate form to enable us to report on the breast screen performance indicators. And there's been some talk for some time about expanding that collection to enable some additional reporting or quality reporting, and we're working with the state and territory program at the moment to look at expanding that collection and what might be most useful for that. That work's only recently started, but it should be finished this year sometime, and then some recommendations will come out from that. But then the process might take a bit longer to actually get them incorporated. We're also looking at reviewing the performance indicators as well. There's been a recent breast screen review looking at a range of different issues. It's currently in the process of being endorsed through our key committees. And until that's available, there's not a lot I can say about it. But there's some of the things, there's a whole lot of things that we discuss, like the funding sources of breast screen, potential review of indicators, the need. At the moment, there are no assessment indicators on the population-based screening framework pathway, which I'll go through in a bit more detail shortly. There's an assessment section, and we don't have any indicators in that for breast screen, so there's potentially some looking at getting some in for that. And in proving data on all colonoscopies, that's a key gap for the National Bowel Cancer Screening Program. We will be undertaking analysis to support evaluation of new or amended program components as the pathways change and as they add bits and extra collection data that they get in the National Cancer Screening Register. We will be doing further analysis to support the evaluation of that. We're looking at improving data for priority populations. There has been some work going on around First Nations reporting for the National Cervical Screening Program. There's another methodology that was developed by an epidemiologist, and we've been doing some testing to have a look and see if that's robust. And at the moment, while it's theoretically a robust methodology, there's potentially need for some more work before we can be certain that the data is valid enough to report. There are some comments on that in the cervical screening report. So at the moment, we cannot report by Indigenous status for participation in the program, only overall. We're also looking at, as I mentioned before, developing new reporting and data products for the cancer screening programs. And we've moved to web-based reporting for all our reports now. And we've also enhancing that with some further developing those with sort of more interactive. We've got some interactive data visualizations in those reports, but we're moving towards some interactive dashboards. We also have developed, we've developed a secure analyst portal to provide raw data back to the department, unit record data back to the department, so that they can promptly deal with policy, to inform their policy decisions and also to inform any sort of program management decisions. And so we're moving our our biannual operational reports for the bowel cancer screening program have now gone on there, and the first quality and operational reports for the lung cancer screening are up there. But there's a range of other pieces of work, like the statistical process control will probably be the next one to move, and also the cervical quality report will be going up this year. And the department are also looking for more timely information on a range of different metrics that aren't generally reported as part of the indicators, but will support policy. Or, for example, I think with the bowel cancer screening program, we're looking at ways of giving them early signs of data. Participation's measured over 2 years, so we're trying to give them. We're giving them monthly or updates on data so that they can track where participation is heading. So it's not participation itself, but it gives you an idea of where it's heading. So that can help inform some of the programs. Okay, might move to the next slide. Thanks, Barry. So I just wanted to highlight here the performance indicators that we have for the different programs, and I'll leave you to go through it in more detail later on. But each of the indicators are set out against the population-based screening framework, which is recruitment, screening, assessment, diagnosis, and outcome. And where the data is available and where possible, we aim to disaggregate them all by age, sex, gender, state, territory, remoteness area, socioeconomic status, Indigenous status, and cultural and linguistic diversity. That's not always possible. Some of these indicators, they were mainly developed quite some time ago. We're talking 20, 25 years ago, when the programs first began. So, and so that they haven't generally changed since then. There might be a few tweaks and things that have changed, but some of them are aspirational, and we haven't been able to get data for them, and some of them have required linked data. And so that leads into some of the discussion that I'm going to have around the linkage projects that we've got. Because one of the linkage projects is to look at for the National Bowel Cancer Screening Program and the National Cervical Screening Program, fill in some of the gaps that require linked data. And in the most recent bowel screening report, there has been some of those gaps filled already, and I'll come to that when we talk about the linkage. There's still further work to do on some of them. But I'll just leave you to have a look at those indicators. They do vary across the programs. So that's that. I might move to the next slide just to show you the cervical screening program. There's a lot more in the cervical screening program, and I will just note that's the main disaggregations we have, but there are also other potential disaggregations that we can do once we get the linked data that are very important for the cervical screening program, and in particular looking at it by HPV status, but I'll come to that in a bit more. And I'll just quickly go to the next slide, Barry, please. Yeah, so, oh, sorry, no, go back, Barry one, sorry. I'm just highlighting the breast screen ones there. So, and there's currently no performance indicators, as I said, for the assessment part of that screening pathway, but we are looking at developing some in the project that's reviewing the indicators. Yeah, now I can go to the next slide. Thanks. We'll just talk about the linkage projects. So the three linkage projects that we've got at the moment in the unit are reporting the key performance indicators for the National Bowel Cancer Screening Program and the National Cervical Screening Program using linked data. And one of the important parts of that is it's the primary pilot, if you like. It's something we've been planning for a long time, but we've been progressing that over the last 12, 15 months, and have, as I said, started to report some of the data for the bowel program, and expect to be able to report some of the cervical data this year as well. This has been used as a pilot to test some of the data infrastructure development work, which Sally's going to talk about a bit later on. And so this is using linked data prior to it going into the National Health Data Hub. The other two projects that we've got going are the National Bowel Cancer Screening Data Linkage Project, looking at adverse events following a diagnostic colonoscopy. And this is also a pilot to sort of look at feasibility. We've almost finished the analysis for that and starting the write-up for that. At the moment, it's likely to be an unpublished report, but it may to the department. but it may end up being a published report, depending on where they want to go. And but it should hopefully fill some of the gaps, or point us in the right direction of what we can do about colonoscopy data. And then the breast screen data linkage phase 2, which I'll just talk a bit more in the next couple of slides. So just for the indicator reporting for the National Bowel Cancer Screening Program and the National Cervical Screening Program, as I said before, it's addressing the gap for reporting gap for the performance indicators. And we wanted to be able to report performance indicators requiring linkage for the first time, demonstrate the feasibility of doing so. And also for the cervical screening program, there's some quality measures as well that require linkage, and we wanted to be able to report on the effects and effectiveness of HPV vaccination, as well as establish and demonstrate the feasibility of doing this. And the data to be linked for all of those includes the National Cancer Screening Register data for both cervical and bowel, the Australian Cancer Database, the National Death Index, and the Australian Immunisation Register data for the HPV. The indicators that we hope to be able to report, or expect to be able to report with the linked data for the bowel program, include colorectal cancer detection, cancer detection rate, and the positive predictive value of diagnostic assessment for detecting colorectal cancer, and the interval cancer rate. And I apologise, something's gone wrong with the slides there, and in terms of those parentheses. And for the NCSP, cervical cancer diagnosed after a low-risk screening test result, and cervical cancers diagnosed by time since last screen. And we also hope to be able to disaggregate by HPV vaccination status, because that's critical to the program and the success of the program, for participation, screening, HPV test positivity, high-grade cervical abnormality detection rate, cervical cancer detection rate, and incidence of cervical cancer. There are a number of other indicators that would be useful with linkage. And for example, under the bowel, there's adverse events around hospital admission. And we can't do that until we link with hospitals data. And we are looking at being able to do that future in the National Health Data Hub. For the adverse events after diagnostic colonoscopy, yeah, as I said, it's a data gap. And we just wanted to find out more about the adverse events with linked data. I think there's key issues around the reporting of colonoscopy. There is a colonoscopy form that is filled out and sent back to the NCSR, but it's not always completed. It's not always timely, and it's not mandatory. So there's issues with that, getting complete data. And there's also issues with the public-private hospital system, and some data you get, some data you don't get, and that makes it difficult to work out. And it's often difficult to work out whether it's a colonoscopy from within program or outside the program. And so this data is looking at exploring all those kind of issues and seeing if we can sort of find out anything more. And so it's the NCSR bowel cancer screening data, hospital morbidity and admitted patient care data, and the national non-admitted patient care emergency department data, and the national death index that are being linked to support that study. The breast screen phase 2 follows on from a linkage project that was done pre-COVID, looking for all three programs and looking at a range of different outcomes. And there are reports up on our website in relation to those programs, and they're found very interesting. And so the key objectives are to analyse gaps that were identified in phase 1 and particularly around breast screening behaviour and cancer outcomes in Aboriginal and Torres Strait Islander women, cancer outcomes by stage and for non-invasive cancer for DCIS, out-of-program screening and pharmaceutical use. And the data that's been linked for that one is, and this is really quite a complex project. It's taken a lot of work over several years to get to the governance phase wrapped up, and we're still at the final little bit of that and hope to be able to get the data in soon. It then is going to take another 12 months to get it all linked and merged and ready to analyse. So it's a bit of a slow project, but it includes 8 state and territory breast screen registers, data from the ACD, National Death Index, MBS and PBS. And this won't be done in the hub. This is done outside the hub. The breast screen data is not in the hub at this particular point of time. And there's also a lot of complications with the Indigenous data governance. So we have, as well as going to all the state and territory ethics committee, our own ethics committee, we have to go to all the Indigenous ethics committee. There's not one in every state, but and for some states, they want us to go out to the regional areas and consult with them as well. So it's a very challenging program, but it's slowly getting to the point where we can hopefully have the data in and agreed and move on with that. But every time there's a change, we've got to go back to quite a number of ethics committees, and so it's a bit of an administrative burden with that project. Okay. The next bit is just to talk about leave you our contact details. And if you've got any questions, although it might be best just to keep ploughing on and wait till the end.
Okay. Thanks, Moira. There is a couple of excuse me, couple of questions in the chat. You might be able to I actually get the next one.
I'm struggling with my I can't. Could you, sorry, Barry, do you mind reading them out to me?
Yep. First one from Lipa. Thanks, Moira. I wonder if you can provide more info about the priority population from NCSP. What's the rates of screening for First Nations and Kalad population? How to work with the service providers to improve rates if gaps identified?
Yeah. Well, we can't currently report participation. There's a number of other indicators that we can report, but we can't currently report participation. There's been a project going on for about 18 months to build on some work that an epidemiologist had previously done to look at them. The data for the National Cancer Screening Register comes from, well, what we call the Medicare spine. So we know who's in the target population by getting the Medicare data and who gets invited. So by using there's a lot of underreporting of Indigenous status. There is some separate work going on, not through us, but outside with Indigenous communities and Indigenous researchers, and to try and improve the reporting of Indigenous status. There's also plans to do further linkage with what's called PLIDA, which is a person-level integrated data asset that the Australian Bureau of Statistics holds, which has census data. So we can sort of try and compare the data that we get, or the unknown that we get in our cohort with the data over there. But that's currently a work in progress at the moment. But yes, there's a lot of underlying issues and governance issues, because it's individuals' rights to, if they want to report their status, and the Indigenous status can be reported differently by by the same person, depending on where they're reporting it, so in different data sets. So there are a lot of challenges with it. And we hope to eventually be able to get to a position where we can use the standard methodology to report Indigenous participation in these programs. But at this particular moment, we can't. And so we're looking at this alternative method. And while it appears robust, there's still some more work to do before we can be sure that the data is accurate enough to report.
Somebody else has asked, any links to occupational, non-occupational, non-intentional exposures identified?
In for which program? Any particular one, or?
No, it doesn't. They didn't
No,
elaborate.
yeah, no, we haven't focused on that.
Okay. One other about the breast screen data linkage. Curious to know what the issue is about pharmaceutical uses.
I'd have to take that on notice.
Okay.
Justin, do you recall what aspects we're looking at? I think it was MBSR items, wasn't it, for certain to identify people who may have breast cancer? Is that what it was about?
For metastatic breast cancer, you mean, Moira?
Probably the linkage that was done previously in phase 1.
Yeah, so there's some Medicare items and also some pharmaceuticals that can be used as indicators for that.
Yeah, like tamoxifen and things like that. Yeah.
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 And Maura, one other, thanks, well done. We've just done some work linking cancer and disability and plans. They're already in Australia.
There is plans to look at disability and develop disability. There's some disability flags being developed that can be used in a number of data sets. Do you want to think,
Yeah, so with the National Health Data Hub that's being developed at the moment, disability is quite a large focus in that. And as Moira said, there's some flags being developed for disability status that will then be able to be used with various other data sets in looking at that. So yes, it is a big focus for Australia at the moment.
Okay, thanks very much. That's all in the chat at the moment. So Justin,
thank you.
Over to you.
Thanks, Barry. So my name's Justin Harvey. I'm the head of the AIHW's Cancer Data and Monitoring Unit, and the presentation will provide a brief summary of what our unit does in relation to Australia's cancer data and monitoring. Next slide, please, Barry. So the Cancer Data and Monitoring team monitors and reports on national cancer statistics and facilitates epidemiological research into cancer outcomes as well. It works in collaboration with the 8 state and territory population-based cancer registries to maintain and improve what's called the Australian Cancer Database, or ACD for short. And we also collaborate with population-based cancer registries, Department of Health and Aged Care, Cancer Australia, and other Australian planners and managers and consumers. And we regularly release various national cancer statistics products. And we also make cancer data available through responding to specific requests for data and in various data linkage projects that include the ACD. The unit also has another team which manages the Australian Mesothelioma Registry. So this registry reports and monitors national mesothelioma statistics to better understand the relationship between asbestos exposure and mesothelioma, assist the development of policies to best deal with asbestos still present in our environment, and to provide sound information for policymakers and researchers. So we manage the AMR, which is a standalone database containing information about all cases of mesothelioma diagnosed since July 2010 in Australia. And it also collects potential asbestos exposure information from participants that take part in the survey as well. And we release an annual report on the AMR. And that data also contributes to various conference presentations and journal articles as well. Next slide, please, Barry. So the Australian Cancer Database, or ACD, is a data collection of all cases of cancer diagnosed in Australia since 1982, including common non-melanoma skin cancers, excluding common non-melanoma skin cancer, every other type of cancer, except for those. It also contains data on some non-malignant neoplasms, so in situ cases, which haven't yet spread to nearby tissue. Cancer is a notifiable disease in all Australian states and territories, and the relevant legislation requires certain individuals and organisations to notify all new cases of cancer to the jurisdiction's Central Cancer Registry. And the ACD is compiled at the AIHW from data provided by state and territory population-based cancer registries, which receive information on cancer diagnoses from a variety of sources, like hospitals, pathology labs, radiotherapy centres, and registries of births, deaths and marriages in each state and territory. So each year the AIHW collects data from all 8 states and territories, the cancer registries in each, quality assures, cleans and standardises those data, notifies registries of any interjurisdictional duplicates. So that's because some cancer cases can be notified to 2 different state and territory cancer registries. So we let them know about cases that we find like that. And we also link the data to the National Death Index to enable survival to be calculated. And we produce the Australian Cancer Database from those data. Next slide, please, Barry. So this slide just shows the variables that are included in the ACD. So that's a list of the types of data that's available in the Australian Cancer Database. And the next slide shows a few more variables. If you could move to that one, please, Barry. So the variables SA1 and SA2, which you're probably not familiar with, are small geographical units that are commonly used in Australia. So an SA2 is similar to a suburb in terms of the size of the population, and SA1s are smaller than this. They do vary by geographical size because of Australia having quite sparse areas and also quite concentrated areas of population. And the other variable, which I'll just quickly mention, is stage at diagnosis data are available nationally for selected cancers in 2011 only. And that's because Australia doesn't currently have national cancer stage data yet. And Sally will talk a bit more about that. So these data are from a pilot that was undertaken quite a few years ago and only for 2011. Next slide, please, Barry. So the Australian Mesothelioma Registry is a national collection of all mesothelioma cases diagnosed since 1st of July 2010, and it's the most up-to-date source of national data on mesothelioma incidence for Australia. Mesothelioma case notifications are fast-tracked to the AMR from state and territory cancer registries, and that's to enable data to be collected on people's previous exposures. And it's particularly important to fast track it because survival for mesothelioma is very poor. Most notifications are still received in the year after diagnosis because of the time it takes to make a definitive mesothelioma diagnosis and the time between diagnosis and notification to cancer registries and to the AMR. The AMR collects data on incidence, mortality, and potential asbestos exposure for patients who consent to take part in the asbestos exposure component. And information on potential occupational and environmental asbestos exposure is collected from consenting mesothelioma patients through a postal questionnaire and also a telephone interview. Next slide, please. In addition to the types of variables that the ACD contains, the AMR also contains the following: likelihood of exposure to asbestos, occupational and non-occupational exposure assessment, occupational exposure by job type, occupational exposure by specific job title, non-occupational exposure assessment through non-occupational sources, and no indication of asbestos exposure based on the available information is important to say. Next slide, please. So in terms of what we release in terms of products and services, what we do for cancer, we release cancer statistics products such as the annual cancer data in Australia, which includes statistics on cancer incidence, mortality, rankings, survival, prevalence, and risk, cancer incidence and mortality by small geographical areas, and various commentaries and reports on specific cancer types, and also on certain population groups that are listed there on the screen. ACD data are used extensively by researchers as well, through data requests that we service, and also through the ACD being used in various data linkage projects where cancers of interest. We release mesothelioma statistics products such as the annual Mesothelioma in Australia report, which includes stats on mesothelioma incidence, mortality, survival, and asbestos exposure. And we also do various conference presentations and journal articles as well. The AMR data are made available to researchers through data requests that we service as well, and also through the AMR being used in data linkage projects. Next slide, please. The cancer data in Australia product provides key statistics about as many cancers as possible. So there's around 170 million cells of Excel data in the 2024 release and over 200 million in 2025. So the aim really is to get as much data published as we possibly can for people to use. It reports on over 100 cancer sites and groups, and there's over 1,000 types of cancer with histology or cell type included as well, because they have different trends and prognosis for survival by histology. It presents cancer incidence, survival, prevalence, and mortality statistics by sex and different age groupings, and includes a written overview of selected statistics and data commentaries on specific topics as well. For example, there'll be one on cervical cancer and melanoma coming out soon. It's released about 4 months after data become available, so an efficient and effective production process is critical because there's so much data. It's expanded each year by reproducing the previous year's content and adding new content each year, which is identified by staff in our unit, data requests, cancer NGOs or non-government organisations, the Department of Health, Cancer Australia, etc. If it isn't possible to produce all the new content in time for the first release, then there's sometimes a phase 2 release, which we're having this year. If it isn't possible to produce all the new it operates on a medium-term plan. So as soon as the work for the current year's release is complete, we move to the next priority information gap. So treatment soon. Next slide, please, Barry. So the following slides just show a selection of the Australian cancer statistics that we publish. This slide shows the number of people diagnosed with all cancers combined each year from 1982 to 2025, as shown in the bars with the counts displayed on the left side of the figure, and the age standardised rate per 100,000 population, which is shown by the line and the right-hand label. The orange bars and line indicate projections, which are for the years that actual data aren't available yet. So next slide, please, Barry. So this slide shows the age standardised mortality rate for all cancers combined. The blue line shows the actual rates, and the purple line at the end shows projections, which are for the years that actual data aren't available yet. Next slide, please. So this slide shows the rankings for the incidence of the 20 most commonly diagnosed cancers on the left side, and mortality for the 20 cancer types that cause the most deaths on the right side, and just shows the rates for each of those for comparison. Next slide, please, Barry. So this slide shows the 5-year survival rates for all cancers combined in Australia, with the trend over time shown on the left-hand side of the screen and the rates by 5-year age groups on the right side. And as you can see, there's been substantial improvements in cancer survival over time in Australia, and survival is worse for older people. Next slide, please, Barry. A new measure that was developed by the Cancer Data and Monitoring Unit a few years ago is age-adjusted relative cancer survival. So the graph at the bottom of the screen shows that the composition of the population diagnosed with brain cancer have gradually become older over time. And this is shown by the light blue and purple sections at the bottom of each bar, which represent older people growing over time. The orange line in the graph at the top of the screen shows the 5-year relative survival rates that are not adjusted for age, and it shows that there are only relatively small improvements in brain cancer survival over time. When we used to only produce these survival rates, some clinicians told us that they were really surprised that there hadn't been greater improvements in brain cancer survival, because there'd been substantial improvements in brain cancer treatment over that time. So we developed this new method which adjusts for age. And the red line at the bottom there shows the 5-year survival rates over time after adjusting for changes in the age composition over time, and shows that there's much greater improvements in survival over time after adjusting for the changes in age composition. So it makes a very big difference for some cancers and not much difference for others, depending on the age profiles. Next slide, please, Barry. This slide shows the 10-year prevalence counts in the blue bars and the rates in the orange line for all cancers combined. 10-year prevalence is the number of people alive at the end of a given year who were diagnosed at some time during the previous 10 years. And as you can see, the number of people has grown considerably over time, and prevalence rates have also increased to some extent too. Next slide, please, Barry. Cancer incidence and mortality risk is also calculated for numerous cancer types. This slide shows the risk of being diagnosed with colorectal cancer before age 85 over time. And note that Australia's National Bowel Cancer Screening Program was introduced progressively from 2006, and that this is around when the change in trend started to occur for incidence. And that's because the Bowel Cancer Screening Program can prevent cancers from developing too. Next slide, please. This slide shows the age standardised incidence rates for mesothelioma over time in Australia. And note that the male rates are much higher than female rates. And this is mainly due to males being more likely to work in occupations in which historical asbestos exposure was more likely to occur. Next slide, please. This slide shows a few results from the Australian Mesothelioma Registry's Asbestos Exposure Survey. It's important to note with these percentages shown on this slide and also the following slides that they're of the population of people who had been diagnosed with mesothelioma. So these people are much more likely to have had previous asbestos exposures. So the figure at the top of the slide shows the proportion of asbestos exposures that were assessed as likely to be occupational, non-occupational, and both. Men's exposures were much more likely to be assessed as occupational than women's, which were primarily non-occupational. The figure at the bottom of the screen shows some broad types of occupations and the assessed likelihood of occupational asbestos exposure based on the information provided by survey respondents. Next slide, please. This slide shows the likelihood of occupational asbestos exposure by specific occupations within the trades module, just to show some of the differences there. Next slide, please, Barry. This slide shows the likelihood of occupational asbestos exposure by specific occupations within the water transport and the land transport modules as well. Next slide, please. So the most common contexts in which non-occupational asbestos exposure was assessed as possible or probable were among those who reported ever having undertaken home renovations that involved asbestos products, lived in a house undergoing renovations, serviced car brakes or clutches, lived in the same home as someone with a job where they were exposed to asbestos, and lived in a house made of fibro. Next slide, please. The following slides provide a brief summary of some newly developed linked cancer data sets and their uses. So we've got 2 linked cancer data sets currently. One that's called CATLINK, or Cancer and Treatment Linked Data Set. So it links the Australian Cancer Database up to 2019, the Medicare Benefit Schedule and Pharmaceutical Benefit Schedule data, and also the deaths data. And we recently linked cancer data and also screening data into the AIHW's National Health Data Hub that Moira mentioned earlier. So similar data to CATLINK, but with some extra data that's available in the hub. And this will provide some really useful data for us to analyse over time. Next slide, please, Barry. So some of the potential projects in terms of using the linked data are looking at cancer care pathways and various different aspects of those, tracking treatment and outcomes for rare cancers, better understanding of cancer and treatment for First Nations people, impact of cancer treatment on future health as well, recurrent cancers, so not primary cancers, costs of health services and medications for treating cancer, being able to describe cancer treatment in a lot more detail and also the costs for that, and describing current unknowns. So a couple of examples of metastatic disease and non-melanoma skin cancer, and lots of other things too. Next slide, please, Barry. So a couple of recent and current projects, just to give some sense of what we're doing with it. Prevalence of metastatic breast cancer, incidence of non-melanoma skin cancer, which isn't collected in the ACD, and estimation of recent incidence or more recent incidence of cervical cancer to measure progress towards the elimination of cervical cancer in Australia. Next slide, please, Barry. And this is just a very quick summary of the project that we recently completed on metastatic breast cancer. So these were the first national estimates for Australia. We found that around 21,000 Australians were living with metastatic breast cancer in 2024, which was a lot more than people had thought. There were 20,800 women and about 150 men. And the number of people with MBC we found is likely to continue to increase over time. And this work is really the first step in improving Australian data on metastatic cancers more generally as well. And it shows what we can achieve through using a collaborative approach with the Commonwealth and also state and territory governments to ensure cancer data is reported in a nationally consistent way. Next slide, please, Barry. So we used new innovative methods developed by the AIHW. CATLINK, which was described earlier, provided a means to count people diagnosed with breast cancer who then commence Medicare Benefit Schedule or Pharmaceutical Benefit Scheme subsidised treatment specific to metastatic disease. And New South Wales developed some methods to count cases using some linked data that they had. And then a few other states, Victoria and Queensland, were able to use a similar method for their own states. Next slide, please, Barry. And as we didn't have access to hospitals, radiotherapy and other data in CATLINK, we used the counts that were produced by New South Wales, Victoria and Queensland. And we used the counts that we produced with the MBS and PBS were adjusted upwards using their estimates. And these national estimates were then compared against estimates calculated using another method, which provided a similar estimates as well. So that's next slide, please, Barry. I think that's it for mine. We might leave questions to the end and I'll have a quick look through them so Sally can do her presentation, and I'll have a look at any questions there are in the chat in the meantime.
Thanks, Justin. I'll just load up Sally's presentation. There you go. Sally.
Thanks, Barry. Hi, everyone. So yes, I'm Sally Rayner. I lead the Cancer and Screening Data Linkage and Development Unit here at the AIHW. So you've already heard from Moira and Justin about the breadth of work that we do in the cancer and screening data space. So I'm just going to take you through some of the newer areas of work that my unit has been leading. And so this sort of last part is really about what's new and where we're heading next with cancer and screening data. So next slide, please, Barry. So one of the biggest new developments has been the launch of the National Lung Cancer Screening Program. So this is Australia's first new cancer screening program in over 20 years, and it puts us amongst one of the first countries in the world to roll out lung screening at a national level. And there's good reason for this. Lung cancer remains our deadliest cancer. As Justin showed in that cancer rankings table earlier, lung cancer is the leading cause of death in Australia, or of cancer death, with around 9,000 people dying of it every year, which is roughly 1 in every 5 cancer deaths across Australia. Now, one of the reasons why it's so deadly is it's often diagnosed at a later stage, and as a result, only around 26% of people diagnosed with lung cancer survive 5 years post-diagnosis. So that's where screening can make a real difference. So this new program provides free access to low-dose CT scans for eligible people to try and help find these lung cancers earlier before they start showing any symptoms. And studies show that when it is found early, more than 65% of lung cancers can be successfully treated. So this new program started on the 1st of July last year, and it's being rolled out by the Australian Government Department of Health, Disability and Ageing. And here at the AIHW, we're responsible for monitoring and reporting on program performance. So very similar to the role that Moira's team already plays for breast, cervical and bowel screening. Thanks, Barry. So to be eligible for the program, people need to meet a few different criteria. So they must be aged between 50 and 70 years. They can't have any signs or symptoms of lung cancer, and they have to have a history of heavy smoking. So the program encourages people to visit their doctor if they think they might be eligible, and they can help the person work out what their pack years is, which is essentially an estimate of how many cigarettes they've smoked over time. Now, to qualify for the program, a person needs a history of 30 pack years. So that's equivalent to smoking 1 pack of 20 cigarettes every day for 30 years, or 2 packs a day for 15 years. So if a person meets these different criteria and they're suitable for screening, their doctor will then refer them on to have their CT scan. If that finds something suspicious, they'll be referred on to a specialist for further investigation. If nothing's found and they're deemed low risk, they'll then be invited to rescreen again in 2 years. Thanks, Barry. So the program's already making a real difference. Since it started, more than 60,000 people have already been screened. So alongside the actual rollout, the government is also funding a public awareness campaign to try and get people to go to their doctor and talk about the program. And they're doing this by showcasing stories of people who've already been screened to try and encourage program uptake. So one of those interesting stories is Patrick. So he's the man showed at the top of the screen there. He's actually the first person in the country to have had surgery for lung cancer as a direct result of the screening program. He went to his doctor for something entirely different, to talk about sleep apnea, but then was referred to the screening program after his doctor assessed him as being eligible. And then within 2 weeks, he'd had his scan, he was diagnosed with lung cancer, and he had surgery to remove his tumour. It was found very early at stage 1, and Patrick is a big promoter of the program as he actively says that this has saved his life. Lung screening can also find other serious conditions as well, particularly emphysema and heart disease. So another story that's being highlighted in this campaign is that of Chris, who's at the bottom right there. Now, he saw the program advertised on the news and he had a history of heavy smoking, so went to see his doctor about the program. While his scan didn't show any signs of lung cancer, it did detect 3 partial blockages in his heart, which he needed surgery to fix. And again, he's convinced that that wouldn't have been found at an early stage to be treatable without the screening program. So we're seeing more and more of these stories now come through, even though the program is still very young and developing. Next slide, thanks, Barry. So now the program's up and running, our role here at the AIHW is to monitor how it's performing. So like the other screening programs, we're responsible for tracking 13 different performance indicators, which you can see here. And we also played a key role in developing these indicators and the broader monitoring framework. So like the other programs, these indicators also cover the whole screening pathway, right from recruitment and participation through the screening process and follow-up assessment, diagnosis, and longer-term outcomes. So we'll publish these indicators in the first monitoring report, which is due out next June. And wherever possible, we'll break that data down by those disaggregations that Moira spoke about earlier. And like the other programs, a few of these indicators can't be reported until we have linked data. So a good example of that is interval cancer rate. That really relies on being able to link the lung screening data with cancer diagnoses over time. So that's something that we'll be able to do as the program rolls out and include in the monitoring reports as that linked data becomes available. Next slide, thanks, Barry. So while the lung cancer screening program is the new big one, there is also some other screening development work happening as well. And the other major area at the moment is for skin cancer. So that's an issue that's particularly relevant here in Australia and in New Zealand. Both of our countries experience some of the highest rates of UV radiation in the world. And as a result, we have the highest rates of skin cancer. So skin cancer is the most commonly diagnosed type of cancer in Australia, with 2 in every 3 people expected to have a diagnosis at some point in their lifetime. And like lung cancer, early detection is really important, particularly for melanoma, and that gives people the best chance of successful treatment. So because of this, the Australian government has invested $10 million to develop what's called a national targeted skin cancer screening roadmap. And really the aim of this project is to develop the evidence base about whether a skin cancer screening program could be effective here in Australia. So the AIHW is involved in this work as well. We're partnering with the Melanoma Institute of Australia, who is leading the roadmap work, to do some new analysis of skin cancer incidence and mortality, and also to help plan the data collection and monitoring requirements that might be required if a skin cancer program was to be established. Next slide, thanks, Barry. Excuse me. So one of the recent analytical projects we completed to support the roadmap focused on skin cancer mortality in priority populations. So we know already that melanoma and non-melanoma skin cancers are among the top 20 causes of cancer death in Australia, but we still don't know enough about which groups within the population are at greater risk of dying. So this project was really about trying to fill some of those gaps. So to do that, we used deaths data linked with population census data in PLIDA, which is that other big linked data set that Moira was talking about earlier. And this has really allowed us to compare skin cancer death rates across priority populations in a way we haven't really been able to do before. So some of these results are quite interesting, so I'll walk you through a couple of them now. And this data is hot off the press. This report was only released this morning, so it's available on our website now if you're keen to take a more detailed look. Thanks, Barry. So one of the things the project confirmed was how closely skin cancer mortality is linked with age. So you can clearly see that here in this chart, where the death rates for both melanoma and non-melanoma skin cancer increase as people get older. But you can also see that death rates for melanoma are much higher, and they're about twice as high for non-melanoma skin cancer across most age groups from 50 and over. And deaths from melanoma begin to rise earlier than for other skin cancers. So that peak starts to happen or starts to increase from around the age of 60, which is about 10 years earlier than for non-melanoma skin cancers. Thanks, Barry. Another interesting finding is how mortality rates differ between our First Nations population and non-Indigenous people. So from previous analysis, we already know that melanoma mortality rates are higher among non-Indigenous Australians compared to First Nations people, and you can see that there in the blue bars. But what's new, and what we can see for the first time using this linked data, is what's happening with non-melanoma skin cancers. And you can see with the orange bars, the pattern's quite different. Actually, mortality rates for non-melanoma skin cancers are very similar between the two populations. So this is a good example of how linked data can help us separate out what's happening between melanoma and other types of skin cancers, and then how those patterns might be different between population groups. Thanks, Barry. Another really interesting finding is relates to disability status. So this is something we haven't been able to look at before, and was mentioned earlier in the chat. So you can see here there's a very clear pattern. So death rates for both melanoma and non-melanoma skin cancers were twice as high among people who were living with a severe or profound disability. And by that we mean people who need assistance with their daily core activities. So this potentially highlights the barriers that people living with disability may face when accessing healthcare. And it's also a good example of how linked data can help reveal some inequities that we might not otherwise be able to measure. Thanks, Barry. And then finally, we were also able to look at how skin cancer mortality varies by region of birth. So you can see here that the age standardised mortality rates for both melanoma and non-melanoma skin cancers were highest among people born in the Oceania and Antarctica region, which includes Australia and New Zealand, and also people born in Northern Europe. Whereas mortality rates for people born in Asia were the lowest. And so that really tracks with what we generally know about skin cancer risk overall. Thanks, Barry. So altogether, this report showed that melanoma in particular, death rates for melanoma were higher among older men, people living in regional or lower socioeconomic areas of Australia, and among non-Indigenous Australians. And it also showed for the first time that melanoma mortality is higher for people living with disability, for people with Oceania or European ancestry, and people working in occupations like farming or labouring, which is predominantly outdoors. And it also highlights how the trends for melanoma can look quite different to non-melanoma skin cancer for different population groups, which is, has clearly important implications for any potential screening program. Thanks, Barry. And as Justin and Moira both mentioned earlier, the other major area that my unit's been focusing on is cancer data improvement. So as Justin covered earlier, there's still some really important aspects of cancer data that we don't cover particularly well yet in Australia. So that includes things like cancer stage at diagnosis, recurrence, and metastatic cancer. And we continue to have issues with the timeliness of our national reporting. So that some of our national cancer data can lag by several years by the time it sort of feeds up from the population-based cancer registries, which can sometimes limit how useful it is in terms of policy decisions, program planning, and research. So my unit's leading a program of work that's really focusing on improving this data and making it more timely, and we're doing that in close partnership with Cancer Australia and the department. So one of the key things we've done under this banner is establish the Australian Cancer Data Alliance. So this brings together consumers and cancer experts from across the country to help improve cancer data and timeliness, and most importantly, to coordinate these efforts nationally. So that's really important here in Australia because a lot of the work happens within the individual state and territories or across major research institutions. So having a body that sort of oversees that work from a national perspective is really important. So as Justin mentioned, one of the first major focus areas has been on metastatic breast cancer, and a key piece of work for the Alliance going forward will be refining those initial estimates with updated linked data, and then looking to develop methods for other types of metastatic cancers as well. Thanks, Barry. And then the final part of our cancer data improvement work is around increasing data linkage. So this is a picture of the National Health Data Hub that we've mentioned a few times today. And this will really help fill those gaps in understanding how people are moving through the cancer pathway. So we already have a lot of data that can tell us this story, but we haven't really been able to join it together in any systematic way. So by doing this on an ongoing basis, we'll be able to start answering some of those questions that Justin showed us about the cancer pathway that we haven't been able to look at in detail before, or across the whole pathway rather than focusing on just a specific part of it. So we'll be linking cancer data into this health data hub, which will bring that together with hospitals information that we get from our public hospitals across Australia, with our major government data sets like Medicare, which tells us about the types of health services people are using, as well as the pharmaceutical benefit scheme, which tells us the type of medicines people are being prescribed, as well as data on deaths, aged care services, immunisation, and we also have some disability data in there from the National Disability Insurance Scheme. So by linking all of this together with the cancer incidence and screening data, will really open up the potential for us to look at a wide range of new research and analysis. And this will also be a key focus of that Cancer Data Alliance, which will help determine the national priorities around what we do with these new projects. Thanks, Barry. And then just as we finish up, I'll just briefly recap what we've done so far. So we've added the bowel and cervical screening data into the hub now, and that's available for researchers to use. We will add lung cancer screening data too, once it's built up enough cases for it to be reasonably linked. We have started progressively linking cancer incidence data from the Australian Cancer Database. We've got 4 states and territories in at the moment, and we're working to bring the others in this year. And we're also looking to partner with 5 clinical quality registries to link their patient outcomes information in as well. So it's a really exciting time to see all of this data start to come together. And I think that's it from me. Thank you, Barry. Thank you, everyone. Happy to take any questions or comments for all 3 of us.
Thanks, Sally. Thanks, Maura. Thanks, Justin. Excellent. We'll open it up for any questions. We've got a bit of time for that. Let me start by saying congratulations to you all and to AIHW. One of the things that has impressed me in your presentation is that you're working with a number of agencies, but you seem to all have very clear roles and responsibilities. You know, and usually my experience is when you get multiple agencies involved, there's lots of competition and pushing and shoving who owns what. But your work seems to be very collaborative and, you know, not stepping on too many toes, but it does seem to be that you've pulled together different agencies, and you also have the added complication of having territories and states involved. But I guess the secret somewhere on the way, I'd like to know how you managed to do it.
It's a really good question, I think, Barry, and it's something we, to be honest, take for granted, I think, with where we're at with it, but it is a challenge, absolutely. And the thing is too that Australia's cancer data is completely dependent on that collaboration between states and territories and the Commonwealth, which has been very good since the mid-80s. And is a really important part of the success, I guess, of cancer data and statistics in Australia. But it's likewise with the Commonwealth departments as well. Having that clear delineation is really important. And our agency has a strong focus on data and statistics. So I guess that helps to delineate some things. So we're not as involved in the policy side of things, more about measuring things that happen post that.
Sally, there is a question here. Does National Lung Cancer Screening Program identify ethnicity-wise information? And also congratulations on a good presentation.
Moira, I'm not sure whether the National Screening Register has country of birth. So ethnicities can be measured in different ways. We think one of the benefits of linking to the census data, it will be really important to get all the information around people's ancestry, country of birth, language spoken at home, and also the countries of birth of their parents, to start putting together that sort of picture about ethnicity. But in terms of without the data linkage, I think we do have country of birth in the actual screening data, but Moira will know better than I will.
We do have it, but its completeness is not good, and it's at a very high level too. So it's Australia or other, and it's often main language spoken at home that you need to go by to work out the cultural and linguistic diversity status. And so linkage is really, the census data is probably really the way to go to get more complete data.
Thank you. Is there any other questions in the chat? Anybody got a question? I know we've got folks from our own cancer screening.
Just a note, Barry, that there was a question for me, but I've put a response in the chat to that.
Okay. Oh, yes, about asbestos. Anything from our cancer screening unit folks who I can see? Any comment, question? Well, there doesn't seem to be any other questions, Justin, Maura and Sally, but once again, many thanks for taking the time. Early morning for you.
It's not too early, it's fine.
That was an excellent presentation, and on behalf of everybody here, we have recorded it, of course, but it's great that also it was great, Sally, that you allowed FONS to host the first public display of some of your recent data. I think we're very privileged on that. But once again, Maura, Justin and Sally, thank you very much. David, do you want to do a closing karakia, please?
Yes, thanks, Barry. Inoi tātou. Unahia ki te uru tapunui. Ki a wātea, ki a mama, tēnā kau, te tinana, te wairua I te ara takata. Koia rā e rongo, whakaria ake ki runga, ki a tina, hui e tai ki e.
Thank you, David. And once again, Maura, Justin, Sally, excellent presentation, and thanks for supporting.
Thank you. You're very welcome. Thank you.
Thanks for having us.
Bye.
Bye.